So I'm taking this occasion just to expand a little bit more about what we have seen this morning, starting from what is the situation right now, what we are doing in CML. Certainly it's extremely important, and also from the logistical point of view, of course, it's a very sometimes a difficult task to achieve, is just to evaluate precisely the response in CML, because drugs are extremely expensive, and we need exactly to know if the patients can benefit of this type of treatment, or if we have to move them in order to other types of treatment, to alternative options, in order to obtain the results that we want. And the first concept that on which I think that everybody agrees is that we have to evaluate two different parameters just to evaluate the response to Imatinib at least, and also to second-generation TKIs in CML patients. One is the degree of leukemic burden reduction. And the second one, however, even more important probably, is the time in which we achieve a certain degree of reduction. And what we have learned is that certainly there is a hierarchic order of responses, of course. Hematologic remission is not enough in CML. We know that hematological remission is just, I would say, from the aesthetic point of view, it results, but from the practical point of view, it doesn't prevent progression of the disease, which is still the major cause of CML-related death. However, the hematologic remission is certainly the first step that we must achieve. At this point, we still have, in absence of any cytogenetic response, 100% of BCR-ABL, of course. But what is more important is that this two-log reduction that can be obtained by moving from hematological remission to CCYR, so complete cytogenetic response, two-log reduction from 100% to 1% BCR-ABL according to the international scale, is certainly the most important part of the response that we have to look for. Because what we have learned clearly, and this is the best predictive value in terms of overall survival. Then we have to continue to monitor our patients by using molecular procedures, because at this point, of course, cytogenetic remission has already been achieved. We cannot achieve a further increased sensitivity. And to do this, we have to use PCR. And what we have also learned in the recent years is if we are going back down of one log with respect to the threshold of 1% of BCR-ABL that we are achieving in complete cytogenetic response, which means a percentage of BCR-ABL of 0.1%, we have a very, very stable response. And furthermore, if we finally achieve, I would say, what previously was called a complete molecular response, that now we like really to define in a more precise way as MR 4.5, which is the limit of detection with the commonly available procedure of the BCR-ABL transcript. Indeed, we know that if we maintain this low level of residual disease for a while, at least 1-2 years, we can also have the possibility to discontinue the therapy without any immediate subsequent relapse. And this is corresponding to a percentage of BCR-ABL to 0.032%. You know that whereas the cytogenetic evaluation is, I would say, rather standardized, and it's, if you want, not so precise as molecular analysis, but being more standardized, it gives us a very good and useful tool. Molecular analysis is very useful, is becoming a very important point, but is not so widely diffused in all the countries. In particular, we do not have really at the moment standardization, I would say full accomplished standardization of this procedure all over the world. Therefore, we need certainly to improve molecular analysis and to spread the use of molecular analysis in CML patients just to have a good idea of what is going on. Considering, however, which were the recommendation of the European Leukemia Net in 2009, at the last recommendation, we know that we are also to have some the timing of the responses to be achieved. Otherwise, we are losing time, and the probability of a subsequent response are becoming certainly lower. As you may see, complete hematologic response not only, but also at least, I would say, a starting cytogenetic response should be seen within 3 months. These were the older data. This field is rather moving quite rapidly now, and we will discuss this later on. But according to the 2009 European Leukemia Net recommendation, this was sufficient after 3 months. Partial cytogenetic response within 6 months, complete cytogenetic response within 12 months, and major molecular response, so the first molecular parameter after 18 months. And these were the data they suggested. But what we can say is that if patients are fulfilling this criteria, certainly the probability that they progress is quite low, but is not totally absent, because until we achieve really the final destination, the so-called safe haven, which is corresponding to MMR, major molecular response, even if a patient is, I would say, apparently undergoing a very good path in terms of response, however, there is still the risk of progression, particularly during the first months of therapy. And the risk of progression, however, is certainly higher for those who are not respecting these goals, the specific time point. As you know, European Leukemia Net in 2006, and then I would say they stated in 2009 in the new edition of, they distinguished 2 different types of non-optimal response. One is clearly the failure, in which there are very few residual probabilities for the patients of achieving later on a good response, and therefore the outcome is not expected to be good as for those who are responding well to therapy. And the other one is suboptimal response. Suboptimal response is an intermediate state in which certainly the probabilities of response are lower with respect to those with an optimal response, but probably not so dramatic. I would say that this definition of suboptimal response has generated a lot of confusion, because it was not clear what to do in case of suboptimal response. Because whereas it was very clear that in case of failure, it was very useful to switch to alternative options. We have discussed this morning, like second-generation TKIs, in specific cases also stem cell transplant. For suboptimal response, this was not clear at all. And this is still a major point, but however, in the recent years, I would say that a number of issues have been raised concerning the treatment of suboptimal response. And the first one is, the first question, which is very important, are all types of suboptimal responses the same? We know that certainly we can distinguish a suboptimal response based on cytogenetic parameters with respect to suboptimal response simply based on non-molecular parameters, in particular not achievement or simply loss of major molecular response. If we are going to see the cytogenetic criteria for suboptimal response, these are just no cytogenetic response after 3 months, less than partial cytogenetic response after 6 months, and partial but not complete cytogenetic response after 12 months. And I would say that this definition, also the importance of evaluating the cytogenetic response after 3 months, and I know that some of you are planning also to move this observation even earlier, but however requested that in the 2009 edition of the European Leukemia Net with respect to what was already established in 2006, indeed another cytogenetic evaluation was introduced at 3 months. And this is becoming more and more important, as we will see later on. So the early response is becoming one of the major parameters just to react. And we must react very, very fast in CML, because the first year of the is one of the very critical one, because we can the progressions that are still observed in patients treated with TKI are mainly observed during the first year. They are progressively decreasing with time, and this is the very important point, and therefore we have to decide in advance if we can prevent the progression, not to wait for 18 months or 1 year or so on. Otherwise we are losing time, and we know that once that progression has occurred, we do not have really at the moment a therapy, apart for very few cases that can be moved with success to transplant. So cytogenetic monitoring, it was introduced at 3 months just to see if there was no cytogenetic response, then less than partial cytogenetic response at 6 months, at partial cytogenetic but not CCYR after 12 months. And what do we, the evidence that now we have accumulated clearly shows that this suboptimal response, in particular the suboptimal response after 6 months, as you may see here in the slide, is behaving more likely a real failure with respect to those with an optimal response. If we are moving from the 6 months response to the 12 months response, you see that the difference instead is not so, is probably more favorable outcome. What does it mean? It means that certainly the residual disease, this is, in my opinion, a double phase phenomenon. In one case, we have more disease at 6 months. The second point is that certainly if we are proceeding with our therapy, we are slowing the risk of progression, and then at the end, at this point, the stability of the clone is probably more pronounced if we are moving from the diagnosis under TKI therapy in the subsequent period of the therapy. Very similar results, as you may see, have been obtained by the Italian group. The previous data were data from the Andy Anderson, sorry. And these data have been obtained also by the Italian group, and many other groups have really seen this phenomenon. Therefore, I would say that now, in our days, we can really consider suboptimal response from the cytogenetic point of view as a real failure, and probably we have to switch the patients, whereas, or to alternative therapies, and whereas there are still very doubtful what we have to do in case of not achievement of major molecular response or simply loss of major molecular response. This is still a problem to be debated. And another point, very important, if we decide to treat and to react in case of suboptimal response, which is the best treatment? Simply increase of imatinib dosage, or maybe we have to move directly the patients to second-generation TKIs? At the moment, for suboptimal responders only, that we have very, very few data. I would say that we do not have data, and we are waiting for the results of this interesting study, in which I know that many of you in India certainly, but also in other countries have contributed, which is the LASOR study, which is just comparing the switch to, in this case, to nilotinib 400 mg twice a day with respect to increasing the dosage of imatinib to 600 milligram for patients with suboptimal, mainly cytogenetic response. And this will be a very, very important study. So, however, I have another point, is that, of course, there is an economical issue, but from the purely scientific point of view, if we have so good results with second-generation TKI already as frontline therapy for similar patients, why we have to wait too long to move them to as second-line therapy to these already registered drugs for first-line therapy, and just avoid maybe the toxicity, the intolerance that can arise with high-dose imatinib. This is something that, of course, for the moment is a simple consideration. There are no data. So once that, as we have seen, that it's so important to achieve CCYR, because this is the best predictive element in terms of overall survival. We have several data. All the data are concordant on this point. Why we have to achieve MMR in addition to CCYR? And the reason is very, very simple. The question of MMR started already some years ago. This is the first publication already almost 10 years ago done by Tim Hughes, and clearly showing that in the analysis and the evaluation of the molecular response at 12 months, those who were in MMR with respect of being simply in CCYR without MMR did have a better progression-free survival. However, in a subsequent analysis in which other patients were included, and this is an analysis done after 5 years, you may see that this significance in terms of event-free survival was lost, whereas there was, of course, a great advantage of being in a complete cytogenetic response, but it was maintained at 18 months. And this explains why the flow chart that we have seen from the optimal response in the previous European Leukemia Net recommendation, why it was still considering MMR as a major point to be achieved, and also, however, after 12 months of therapy. But there is another reason, however, that CCYR, corresponding to a certain plateau of residual disease, however, gives a sort of instability of the response. Indeed, these are the data obtained from the IRIS study, but there are also other data from independent studies, like the Hammerschmidt data, the MD Anderson data, and so on, clearly suggesting that if you do not achieve MMR, in addition to CCYR, your response is less stable. And at least 1/4 of the patients subsequently is losing CCYR, and loss of CCYR is a failure of the therapy, whereas loss of MMR is not a failure, but only something that you have to look carefully. It does not allow you to change therapy, does not allow you. Of course, it's not suggested to change therapy. Indeed, if you are losing CCYR, this is a failure, and a change in therapy is strongly suggested. And this is due because the amount of the residual disease is clearly associated also with a resistant disease. And this resistant disease is confirmed by the fact that the point mutations that we have seen before are so important to confer resistance to CML patients are progressively decreasing if we achieve lower level of residual disease. This is a slide presented by the Australian group, but all the data are in favor of this hypothesis, that really what remains is not only constituted by so-called progenitors, but by resistant progenitors. And therefore, this is a dangerous reservoir of cells that can still progress because in them some residual TK activity may persist. So we can really call MMR as the safe haven. And most of the current therapeutic approaches try to achieve MMR. I would say that this is also one aspect to be underlined. But probably one of the other very important points is certainly represented by the fact that the probability of achieving CMR, which is becoming probably the most important aim, as you have discussed this morning in CML, is really depending on the rapidity of the response. If you achieve MMR by 6 months, or between 6 and 12 months, or after 12 months, you may see the probability of achieving later on CMR are certainly progressively decreasing. And we will see that now the new data clearly confirm this point. So the rapidity of the response is clearly correlated also with the possibility also of achieving MR4, MR4.5. If you want, you can call it CMR, and therefore to have the possibility of discontinuing the therapy. If you do not achieve MMR by 18 months, your probability are 0 to achieve in a reasonable time, let's say 5 years, as in this slide, a sufficient decrease of the residual disease. And another point which is becoming very clear, if we are using a stronger inhibitor of the BCR-ABL tyrosine kinase activity, we are greatly increasing, doubling in this case, the number of patients who are achieving CMR. And 1/3 of the patients treated with nilotinib in total, and 50% of those treated with imatinib indeed achieve CMR already within 3 years after the start of the therapy. These are the data of the NEST-ND. These are probably the most important data that we see updated at ASH 2012. We do not have the data, but we expect that this difference will further increase in the future. So inhibition of BCR-ABL in a more potent way is clearly able to induce more molecular response. And this is, let's say, what we expect in order to have the possibility to try to discontinue the therapy. Because you know the data, these are the very early data presented by the French group. Now we have more mature data also with a longer follow-up, clearly suggesting that approximately 40% of the patients treated with imatinib and who achieved complete molecular response for at least 2 years are still in a complete molecular response even after discontinuation, even after a follow-up of 3-4 years. We do not know if these results could be better using second-generation TKI at the moment, but we are working on this. So it's clear that CMR is becoming the real goal that we must try to achieve in CML. And in this, of course, panorama, I think that also the stem cell transplant, as we have seen this morning, can still play an important role. So the last point that I want to touch is important to achieve a fast response. Of course, this is, I would say, an academic question. You know already the answer. But this is a very hot topic, of course, in our days, because you may see that in 2010, already 2 years ago at ASH, the German group first presented this data, clearly showing that a threshold of 10% BCR-ABL at 3 months was predictive of progression-free survival, event-free survival, and we now know also of overall survival. And the paper was published only recently on leukemia, and their paper, however, clearly suggests that not only the molecular cutoff of 10% BCR-ABL, but also the cytogenetic analysis, 35% above or below 25%, therefore partial cytogenetic response after, or at least partial cytogenetic response after 3 months, was predictive of the future outcome in terms of progression-free survival, as you may see, with a statistical difference, and also in terms of overall survival. So cytogenetics as well as molecular analysis was predictive of the future outcome already after 3 months. And these are data presented almost 1 year ago at TASH concerning the decision study, and clearly showing another extremely interesting point. The fact that the 10% threshold is not only valid for Imatinib, but is valid also for second-generation TKIs, in this case, dasatinib 100 milligram. You may see that the shape of these curves is extremely similar, doing very well those who are below 10% with both dasatinib and Imatinib. Not so good for those patients, even worse if you want, for those who are above 10% with dasatinib after 3 months. And this is quite logical because you are applying a stronger therapy, therefore you expect better results. If you have the same threshold independently from the TKI that you are using, it means that you have, of course, a more resistant clone. Which is the difference at this point? The difference is that this is in terms of, sorry, the one was progression-free survival, and this is overall survival. Again, absolutely the same shape of the curves. The difference is the percentage. The patients, the number of patients who are within one category or the other is clearly different if we are using dasatinib or if we are using Imatinib. And this is true from the molecular point of view, is also true from corresponding really to what we see from the cytogenetic point of view. So this has been now proved in a number of studies, and clearly is totally changing the way in which we must perform the analysis. We must anticipate the analysis and to take our decision very early on during the treatment of the patients. And of course, we can obtain better results with second-generation TKIs, but that with respect to with Imatinib, because we are really moving some of these patients from the bad categories, let's say, to those who are responding. And very impressive data have been presented also with nilotinib, in particular nilotinib 300 milligram. As you may see that again, those who are subdivided in 3 categories, those above 10%, in between 1 and 10%, or below 1% after 3 months of therapy for both drugs, you may see that in terms of response, the numbers are exactly the same in all categories. What changes is the number of the patients. Here are 145, and this means that 50% of the patients falls in the category of those with below 1%. Here only 43, therefore approximately 1/4 of the patients with respect to nilotinib. And this is extremely important because those who have a very, very fast and good response have a higher probability, 53 or 50%, of achieving not only MMR, but also CMR within 3 years. And therefore, this is a category of patients in which we can expect to have the possibility to discontinue the therapy without a subsequent relapse. And these are concepts which have already been inserted in the guidelines provided by the NCCN. As you may see, they are already clearly stating that 3 months, 10% using a standardized qPCR, but also the cytogenetic analysis in terms of partial cytogenetic analysis is the main discriminant for the response. And of course, they're very simple, I would say, in my opinion, very effective suggestions. We are a little bit late with the European Leukemia Net because it's involving more people and there are disparity of opinions. What I can anticipate is that indeed there is now a quite clear definition of the good response, or if you like, optimal response, although I do not like the term optimal response, in terms of achieving at least partial cytogenetic response and less than 10% at 3 months, CCYR or less than 1% after 6 months, and at least MMR or 0.1% BCR-ABL after 12 months. If you want to also after 2 years, MR 4.5, so 0.01% BCR-ABL. There is, I would say, it's not so clear if we have to further distinguish the non-optimal responses in 2 categories. We do not like the term suboptimal response anymore. It will be probably substituted by another term like warning, which means that you must be careful, or just to consider an entire category of failing patients, a unique category of failing patients in which all those who are not optimal responders may enter this category, and leaving to the doctors to, of course, to decide individual patients. This is better just to observe them, or to move them to more aggressive therapies, to move them to also to stem cell and so on. So for what probably will be at the end, we do not know, is just to say, okay, not to be extremely, let's say, compulsory, but just to simply say, if the patients are responding well, please do not change therapy, because everything is okay, you cannot obtain better result than this. If the patient is not responding well, please consider alternative options, although in some cases these options are real options, in other cases are only desired option but not real options. And this is what probably in the future will come out. Thank you very much for your attention.
Thank you very much, Professor Saglio. Any question from the floor? Is it possible nowadays to omit cytogenetic study, do only molecular study?
It's possible, but it's better to perform both types of analysis. I would say that you have a confirmation of what you're observing. Of course, cytogenetics is, in my opinion, still very important. Probably molecular analysis, if standardized in the correct way, is even more precise, the cytogenetic analysis, but it's better to rely on 2 methods at the moment.
Thank you. Questions? Yes.
In your last slide about the year-end 2013 criteria, at 6 months, is the 1% is cutoff point is consensus or not? Recently in Taiwan, we have analysis about this issue in over 500 CML in chronic phase. And we didn't see the difference between less than 1% and between patients with 1 to 10%.
This is a very good point. Yeah. I think that this is still under evaluation, I would say, because there are very few data. There are many data, and the whole, let's say, concordant at 3 months. The data at 6 months are still under evaluation. You are perfectly right. However, I think that it will probably become, I would say, because it's very, we have less events, and therefore having less events is very difficult to find. You have to, in the study, to introduce a lot of patients to have an answer to this precise point. Of course, it's quite strange if we are seeing a lowering of the disease. It's quite strange that those who are above 10% after 3 months are not below, who are below 10% at 3 months are not below 1% after additional 3 months. It means that there is a very good correlation.
Thank you.
Also, I would say that this time point is also depending on the goal that you want to achieve. If you want to achieve, complete molecular response, you have to be below 1% already at 3 months. So this is evaluated mainly in terms of progression-free survival. But if your aim is different, of course, you have to look at different parameters. This is another very important point to be taken in consideration.
Thanks, Professor Saglio. Again, another elegant talk and making it very clear. Now, one of the things like 10 years back, we used to use a lot of interferon alpha in chronic myeloid leukemia, particularly in chronic phase, and it did make some difference at that point of time. After that, there were some papers by French group and others that it may still have some relevance. Would you like to make any comments on today's scenario, especially like Asian countries where the interferon is still available and it's cheaper compared to these newer agents? Do you think it could be like once you achieve complete cytogenetic remission or molecular remission, any point of putting on so-called maintenance by interferon?
Absolutely. This is another very, very important point. You have mentioned the French study clearly showing that there is an improved major molecular response and also what they call optimal response, which is MR4, in patients treated from the beginning with the association between imatinib and interferon. There are several studies now trying to test the association between second-generation TKIs together with pegylated interferon. Pegylated because all the studies which were not using pegylated interferon generally failed to show the same phenomenon. So it seems that there is something special with pegylated, so it's a very complicated time. I think that interferon can be useful because we know that it's working in CML by lowering the number of the progenitors and therefore maybe also by facilitating some graft, in this case, sort of immunoresponse against the leukemic cells. But I really do not know exactly if this will be able to prevent the progression of the disease that we observe in the very, very early time point. So in my opinion, it would be a very good way probably in the future to be explored, to be fully explored, just to induce or to maintain, as you said, good molecular response, complete or at least major, without avoiding the TKI therapy.
Just like blast crisis is another difficult situation. Unfortunately, 4-5% people still do progress to blast crisis. So once they are in blast crisis, what is your day-to-day practice?
I would say that we are trying just to obtain a remission, but once that we have obtained remission, we try to move the patients to some sort of stem cell transplant. This is the only possibility that we have right now. Remissions sometimes can be obtained even simply by changing TKI, or in particular also ponatinib is quite good in this context, but in some cases you needed to add some form of chemo, but without stem cell transplant, no probability of success.
I have a question.
Yes.
So Dr. Saglio, at some time, I think was it last year or a year and a half ago, there was an editorial in JCO, Dr. Hagop Kantarjian and Jorge Cortes wrote an editorial on monitoring the depth of responses and particularly keeping the CCYR as the gold standard. One scenario is you have a patient that has attained CCYR and perhaps major molecular remission, loses the major molecular remission. I think in that editorial they say that you don't have to make treatment judgments based on that particular situation. It may be an unstable situation. It's possible that the patient may go back into a major molecular remission. I know you also pointed out data from Dr. Marin's group and Hughes and others showing that CCYR, but not being able to achieve MMR is unstable. I mean, there's still some controversy or some confusion.
No, I think that the problem is that sometimes some of this instability the simply loss of MMR. Not the lack of achievement of MMR, in my opinion, is even worse with respect of losing MMR, because in most cases, loss of MMR simply without loss of CCYR is due to lack of compliance or adherence to the therapy. And therefore, if there is a mutation, which is not frequent, in our series is very low, in some other series may achieve at maximum 10% of the cases. In these cases, you have proved that there is the onset of a resistant clone. But in all the other cases, you may wait to subsequent analysis before deciding to switch the therapy. And you must also check, I don't know exactly in which way, but the adherence to the therapy of the patients.
Thank you. And the other question I have is about the international scale. Dr. Susan Branford is very forthcoming in trying to make this universal, but we don't do this in the United States. I know you sure you do it in Europe. From your own perspective, since we're outside the US and outside Houston, what are your thoughts on why this is not the case?
I think that there has been some exaggeration concerning the molecular analysis and the standardization of molecular analysis. Indeed, a non-standardized analysis like a cytogenetic analysis, I would say roughly standardized, is working very well for CML. So I think that to be precise is okay, but probably this certain degree of precision is not really needed. We must aim to the perfection, but we know that in real life we can accept also something less. So standardization is extremely important. It can be achieved by using, I would say, reagents, conventional reagents already prepared and that everyone can use to calibrate his molecular analysis in a simpler way. This will be done in the future. Of course, in the future, but there is also an economic concern. It will be possible to perform the analysis in a very with an almost automatic way. I would say this could be useful, in particular for the states where there are no economic constraint or very little economic constraints, and it will be useful also for specific places in which they see a patient every 3 months and they want to have an immediate analysis and immediate evaluation of the response without going back to the patients after 2-3 weeks because it's too long. So we needed to simplify all the process, even because the number of the patients, of CML patients, is progressively increasing, as we know, as we are saying them. So this is becoming a huge amount of work, and we needed to be very, very practical and simple in our approach to these patients.
Professor Saglio, in patients with the CML who first come with the accelerated phase without any TKI treatment before, what is your preferred?
I prefer in these cases, of course, to use second-generation TKIs.
Which one?
In my opinion, I'm generally using nilotinib 300 mg twice a day with respect to dasatinib, also because in Italy it's cheaper with respect to dasatinib. It's only 20% more than imatinib, whereas dasatinib 100 mg is still almost double. And this is the main reason, I would say. And then because 300 mg nilotinib is probably the best balance between the efficacy and the toxicity with respect to other second-generation TKI at this dosage. This is my personal opinion, of course, but an indication can also be to start with imatinib 600 mg.
And if you can induce the hematologic response, complete hematologic response, would you go ahead for transplant, or you just continue the second generation TKI?
Depends, of course, if I have a very good donor, but the patient is very young and so on, so I'm particularly concerned about the risk of progression. I would move the patients, most of the patients should be moved to transplant in accelerated phase.
Thank you.
Just a little away from the therapeutics. chronic myeloid leukemia appears to be slightly more common in the developing countries, like in Asia. And I mean, there may be lack of population-based data, but then the hospital-based registry and some of the population-based registry tells us that the probably incidence seems to be higher than what we have in the Western world. And we also have at younger age. I mean, we know that Philadelphia chromosome is the region for CML. But what really starts this process? Have you ever thought what could be some kind of infective process? Because we have slightly higher incidence, more in the younger people. Could there be infection which may be triggering to leading to this translocation and leading to this whole process of CML? Have you ever thought about that? What could be any ideas about this?
But for the moment, there are only suggestions. Certainly, we know that environmental factor can play a role in facilitating the translocation. Time ago, we discovered also what we call a duplicon, which is a part of duplicated chromosome, which is just, not just, it's 1 megabase before the Abelson gene on chromosome 9 and 150 kilobase, so not far away from the 3' end of the base. This is a duplicated part of DNA, and this may favor the combination of these two genes. But of course, all the others are speculations. At the moment, we do not know. I think that environmental factor and radiation in particular have been implicated in the genesis of the translocation. But why hematological I would say neoplasias prefer balanced translocation with respect to other mechanism of this is not clear at the moment.
Professor Saglio, do you think some hypomethylating agent can destroy the residual leukemic stem cell in CML?
We do not know, really. At the moment, this is a good question. This is part of the investigational trials that we should promote in the future to try to, because it's clear that our target is moving, and this is becoming more and more evident. That's why I do not agree with the fact that what we must aim is only CCYR for our CML patients. Otherwise, our CML population will expand too much. We need really cured CML patients, not only controlled CML patients, because probably in the future we will not be able to afford the number of these patients.
Any more questions? If not, thank you very much, Professor Saglio, and then